was guidance and worked examples that were more relevant to care homes. And I think as well, what we hadn't fully taken account of was the number of care homes, the range of whether both public sector, private sector, voluntary sector, the number of different employers, and therefore the additional challenges of making sure that staff actually are aware of the guidance and trained in it.
Moving on to the test and protect hat that you wore, as it were. Yeah. 7th of May 2020, the Scottish Government announced that they've managed to get to 3,500 tests a day, and they're trying to ramp it up to 8,000 tests by mid-May. How many tests did you need at that sort of time in order to make test and protect, we'll go on to quite exactly what that means, a functioning system?
I'm sorry, I can't recall the actual modelling that was done around that. What I do recall is that during May, and as no doubt as a consequence of the national lockdown, the rates of COVID reduced quite substantially. In fact, when we first launched contact tracing for Test and Protect on the 28th of May, case numbers were very low.
Perhaps a simple question.
Yeah.
The Enquiry's heard evidence that the principle is test, trace, isolate.
Yeah.
Some people it's called test and trace. Why was it called test and protect in Scotland?
I'm not sure I can give you a direct answer to that. I think it was it started off the policy was described as test, trace, isolate, support, so TTIS, and maybe test and protect was just thought to be a bit snappier in terms of communicating to the public the intention, because the intention was to test people both in order to protect them and protect the rest of society. Now, behind that, absolutely, there were 4 pillars. One was testing, contact tracing, isolating, and providing people with support for isolation. So, in terms of the delivery of the programme, we were working across all those aspects. But I think Test and Protect was just designed to be a name for the programme that the public could relate to and that they would engage with and be part of.
But one could ask, why is it called Test and Trace in England?
Test and Protect is announced on the 26th of May 2020. Contact tracing goes live 2 days later.
Yep.
Prior to that, presumably there's quite a lot of employing contact tracers, because at this stage, to be clear, this is not the app that...
Yeah.
So this is someone tests positive and someone has to give them a ring and say, where have you been in the past 5 days? Is that the position?
Yes, that's absolutely correct. The contact tracing was based on people phoning up. So they would speak to somebody tested positive. They would get a phone call. They would be asked to talk through their contacts, and then So you're right. Yeah.
So inherently, kind of reliant upon the memory of the person who's testing or who's tested positive. Sometimes in circumstances where they might be quite unwell with their COVID infection. It relies upon the honesty of that person, and it relies upon the ability of the contact tracer to properly take someone through their story. Is that fair?
Yes, I think that's fair. Yep.
So what training did contact tracers, for instance, have to undergo, and how long did that take to set up?
Yeah, so we started, the way in which we approached contact tracing in Scotland was to build on the existing local health protection teams in our NHS boards. So we looked to scale up those teams, but to augment that with a national contact tracing capacity that could be used to support local systems where they were experiencing peaks in infection, And also that increasingly became an approach where the local health protection teams who had the sort of more detailed knowledge locally would deal with the highest risk cases from the highest risk settings, and the national team would deal with the more straightforward risks. So in terms of training, public health, we worked with Public Health Scotland to develop the core scripts for contact tracing. We worked with NHS Education of Scotland, to our education board, to put in place training packages. As you say, all of that stood up really, really quickly. So we went through a process. We also stood up the actual contact tracing system itself to enable all of that to be logged, and it was important to us to have that as a national system so that it would be possible for the national contact tracing facility to actually step in and support boards, because everybody was working off the same system. So the education and training packages were put in place during the course of May. When contact tracing first launched, a lot of boards had, because not all NHS services were operating, so a lot of boards redeployed existing members of staff into their health protection teams to provide that additional support. It was an internet-enabled service, so it didn't mean people had to be sitting in a call centre. They could work remotely, which was again incredibly helpful in terms of getting that set up.
So going back, taking that in stages, you say that was basically happening in May.
Yeah.
Lockdown comes 23rd of March. It's known that pandemics, whichever kind of pandemic, testing, tracing, isolating contacts is a key part to try and get on top of the spread of a virus. Why was contact tracing only stepped up in May and not on the agenda, getting things moving 3 months earlier?
So that it absolutely was on the agenda. So it absolutely was on the agenda, and we were talking about it from, I think, April, early April, possibly earlier. But I'm speaking here very much from my experience. So I was brought into the process on about the 5th of May. At that point, Public Health Scotland had already been working up what were all the different work streams that were needed. So the thinking on that was already well advanced. I think it was a combination of getting to the point where we would have the testing capacity available, and also, again, my understanding is that contact tracing, the WHO would indicate that there is a level of transmission within the community at which contact tracing is not really viable and not the best use of resources. So we had to get back to having a lower level of transmission in the community, and then be ready to launch the process, which we were.
So it goes live on the 28th of May. About a month later, on the 21st of June, I think leaflets are sent out to the public, sort of explaining what it's all intended, why it's happening, and sort of giving more detail. Was it being found that people were simply not understanding the principle of test and protect? I'm sorry, but I can't recall the reason why those leaflets were sent out. What I do recall is that in the first few weeks of operation of the test and protect system, there were, as I've said before, extremely low case numbers. And whilst that might be a really good way to test a brand new system, actually, in terms of that wider public knowledge of that, maybe it probably meant that there wasn't a huge amount of activity going on for the first couple of weeks. Fast forward a little bit longer to when it moves from contact tracers and then moves into producing an app.
Yeah.
So 10th of September, I think, is when the Protect Scotland app goes live. It's again, just so we're clear, this is sort of the pandemic and all of the things that were in the press at the time, designed to work on phones to physically locate you next to someone, and so trace contacts in that way.
Yes, that's correct. Yeah.
Did the human contact tracing then come to an end at that point?
No, it didn't. We very much regarded the app as being an additional tool in the toolbox around contact tracing, and it was very much there to support people to look after themselves as well, in terms of both knowing that they'd been in contact with somebody. So no, the human contact tracing continued, and we also continued to develop our digital approaches to contact tracing, which included if you've got being able to send digital forms to people for them to fill in with their contact details.
And the app launches on the 10th. Within 24 hours, 600,000 people have downloaded it. And within a week, I think it's about a week, there are 100 people that are told to self-isolate. What studies were going on to make sure that it was actually working?
I'm sorry, I'm not sure I can answer that, but by the time we got to that point, I was actually working on the vaccination programme, so my recollection, obviously I was aware of the app being developed, and my digital directorate would have been very involved in that, but I need to refer you elsewhere for details around.
You may therefore not be able to help with the next question, but I'm going to ask it anyway,
Okay.
and if you can't help, just say so. 11th of November, it's announced that there's been a coding error in the app, and so the estimation is about half of those testing positive, their contacts aren't being traced properly. So there's a chunk of people who've just gone missing under the app. Do you have any insight into that? Can you recall that?
I can't specifically recall that. I guess what I would say is that the fact that we still had the physical contact tracing capacity in place, so we were at no point were we relying just on the app.
And I think the next day, so the 12th of November, there was a announcement that it was felt that something like 8% or 3,500 people had not been traced by contact tracers since the beginning of July. So that combination of the app perhaps not working so well or something going wrong in the coding, and the contact tracers not making contact with about 3,500 people does suggest, doesn't it, that there were people falling through the gaps, and that inevitably led to infections that because people weren't isolating because they didn't know they had to.
Yeah, so absolutely accept that, and I do recall our concerns about the when the contact tracing centres were making multiple calls to people who were contacts but had not been able to trace them, had not been able to speak to them. So yeah, there were issues around, and particularly as life got a bit more back to normal and people had more contacts.
And as life got back to normal and sort of more people moving around as well, yeah. We hear the phrase regularly, the virus doesn't respect borders. But it's right, isn't it, that Protect Scotland was a different app to the app that was in England. And so if people were crossing the borders or contacting people from England or vice versa, that app wouldn't necessarily pick up those contacts. Is that right?
So it was a different app. We took a different approach to information governance around the development of the app. I think we worked pretty hard with the other UK nations to try and make sure that they were compatible. But I'm sorry, I don't know the detail of the extent to which they were compatible or not. Again,
because you moved on to different roles, it may be that you're not able to help so much in terms of the status app. So that was the I appreciate you were involved in vaccines at the time, so it may be that you've got some oversight of this. But in September 2021, so sometime later, there's the COVID status app is produced or is set out, and that's effectively the vaccine passport. Is Is that right?
That's what it came to be called. Yeah.
Colloquially called the vaccine passport. And that was released at a time when infections were getting higher and higher in Scotland, September 2021, hit by the Omicron wave. Was there a risk, or did it occur that the vaccine made everyone, oh look, I've got a vaccine. This is my passport to freedom, in circumstances where society is opening up, but infections are climbing rapidly?
I think you probably need to ask a clinician for a view on the extent to which maybe that, or a behaviouralist. I think that it was the case that I think one of the reasons, one of the part of the thinking behind having the vaccine status app was to absolutely to encourage people to take up vaccination, because that was, our single route towards protecting people better.
If we now move to a completely different area, okay. Shielding, and the involvement of your department in shielding broadly, not in a clinical sense at all, but in terms of the impact of shielding on decision making by ministers in Scotland. So a shielding programme is implemented in mid-March 2020. When was shielding first on the agenda, as it were, in the department?
I think there were discussions from quite early on, as it became clear that the threat that we were facing from the pandemic, about how we could protect the most vulnerable. So I was aware of conversations, particularly around the CMO, the CNO, and then the four CMOs. Again, my understanding, four CMOs worked together to develop the list, the definition list of those who were felt to be most vulnerable to the virus. We worked with Public Health Scotland, with colleagues in local authorities, to try to come up with as complete a list as possible. And clinicians locally had the ability to add to that list. So if they felt that if a general practitioner felt that they had somebody who wasn't on the list but should be, then they could add those on to the list. So it was formed part of our discussion from a pretty early stage, both in relation to identifying and categorising that shielding list, but also then what were we going to put in place to support those people. And
again, sort of expanding into the social care side of the DHSC title, you've got people who are clinically extremely vulnerable as a result of their pre-existing conditions or treatment that they're undergoing. But you've also got people who are vulnerable because of health conditions that wouldn't make them necessarily more vulnerable to the virus, but are unable to access society in a result of things like lockdown and the like, and perhaps feel more vulnerable whether or not they are in the clinically extremely vulnerable list. So practicality in sort of shielding policy and ensuring access for people. The Enquiry heard last week that effectively a two-tier approach to shielding developed almost accidentally, because highest risk list were given access to services with a priority for online delivery slots and prescription deliveries and that sort of thing. But people who were not at the highest risk under the clinically vulnerable analysis, but still vulnerable as a result of, for instance, their disability, meant that they were in a second tier. They didn't have that priority access, and they didn't have that. They were reliant still on other people to assist them and give rise to greater risk for them. So, was there any thought put to the fact that people might be deprioritised under the shield because of the overly not necessarily over focus, but the focus on shielding necessarily meant that services might be being removed or made harder to access to others?
So I suppose to respond to that in a couple of ways. Firstly, I don't think there was ever any intention or to somehow sort of ration support that was available, and to focus that at the clinically vulnerable group. Our local authorities worked through their local resilience partnerships and through using their I can't remember precisely what they call them, but their list of the most vulnerable people that they would use in relation to other sort of civil emergencies, etc. They worked, I think, really hard, as did many voluntary organisations and others. So I think that the shielding list was very much about those who were clinically vulnerable, but there were other support mechanisms that, as I say, I know, I don't know the direct details, but I know local authority colleagues worked really hard to put in place around people who weren't clinically vulnerable but would be vulnerable for other reasons.
To what extent did things like the data issues that we've already covered cause problems in making sure that those vulnerable, not the clinically extremely vulnerable, the vulnerable people didn't fall? Or did that lead to them falling through the gaps?
I don't think I could answer that one, I think, because that will depend on how good the data was that was held at a local authority level, and that may well differ from one authority to the other.
You spoke earlier about the recognition of inequalities and inequalities in health, inequalities in social economic status and the like. In one of the corporate statements, INQ 000215470, paragraph 46, you say that the advice was CMO's advice was based on what was considered best for Scotland, having regard to the health status of the Scottish population and its characteristics. Noted that it's an older population than the average UK. It's all right, you don't need to go through it line by line. And multimorbidities, more multimorbidities, so greater vulnerabilities, greater risks, different socioeconomic risks, different ethnic group risks than in the UK as a whole. You say in that statement that when there was a divergence of approach to NPIs in Scotland compared with other UK nations, this was driven by differences in the Scottish population and other factors. Advice was given solely on what was considered genuinely considered to be appropriate for Scotland, where it was possible to achieve consistency with the other UK nations. That was desirable, but it was not always possible. Why wasn't it always possible?
So I think that for two things. One, you referred to the different characteristics of the Scottish population, and I think as a result of those characteristics, older population, more multimorbidities, we were inclined probably to be more cautious because of the nature of that population. I think the second area is there are also things that are just different. So, for example, school terms are different in Scotland than in England. So there were some things around decisions around schools that just needed to be different because we have a different system.
The inquiry has been provided with various papers in this regard. Presentation from Scottish, it again doesn't need to come up, but just for the transcript. Presentation from Scottish Government's Communities Analysis Division, which is the impact of COVID-19 on equality groups. Disability analysis was undertaken in October 2020. And there was a report from the Scottish Government titled Coronavirus Impact on Equality Research, September 2020. So there's research being undertaken about the unequal impact of the virus and the underlying inequalities. what concrete measures were being put in place to combat those inequalities in the second and third waves of the pandemic, when looking back, and because you see these reports, so what are those reports being operationalised into in order to protect those who are more vulnerable for the various inequality reasons?
I would say that the key aspect of that was in relation to the vaccination programme, with vaccinations being the thing that we could most positively do to protect everybody. And the vaccination programme had its own separate work stream around equalities. And that was all about trying to ensure that we didn't just, wasn't good enough just to hit the standard level of take-up for vaccinations. We needed to push it as hard as possible, and we needed to try to ensure that we removed as many barriers as possible in relation to people from different communities, whether they be ethnic minority communities, whether they be gypsy and traveller communities, whether they be some of our more socially disadvantaged communities, and ensuring that it was that vaccination was easily available and that people were supported to get vaccinations. The testing, our approach to testing also developed in relation to understanding some of those inequality impacts, and again with mobile testing units, with very local testing units, and again trying to ensure that as far as possible we were reaching every corner of Scottish society.
Because some communities might be less likely to come forward for tests, and some communities might be less willing to come forward for vaccinations.
Yeah, that's absolutely right.
Turning then to NHS capacity in Scotland. The start of the 2020, you were involved in ICU capacity development, but I want to look at it in two stages, very briefly. The ICU capacity, and then there's broader NHS capacity issues, both of which I think fall within your pile of things that you have to get through on a daily basis. It's an often repeated comment, both in this inquiry and in broader circumstances, that one of the lockdown was to stop the NHS being overwhelmed. And there was ICU, that relates to both ICU capacity in terms of just simply not having enough ventilators, etc. If the virus became, if everyone needed a ventilator, there simply weren't enough ventilators to go around. Equally, not everyone needed a ventilator, but needed a bed and varying levels of clinical assistance in hospital settings. In the first 3 months, is when you were looking at ICU capacity, what was being done in the non-ICU capacity expansion plans?
So in terms of the non-ICU capacity, I think two things. First of all, recognising that we have the physical infrastructure that we have. We were concerned, obviously, about the number of beds, but actually probably more concerned about the people to staff those beds as well, particularly when healthcare workers are not immune from becoming ill with COVID as well. So that was why we were focused on really trying to preserve the capacity that we had in the NHS for the people who would most need it. So we knew that we needed to obviously support people with COVID, but on top of that, retain the capacity to deal with emergency unscheduled care, and also to keep cancer treatments, for example, going. So as a result of that, we stood down a lot of our elective capacity. So a lot of the planned care didn't happen during that period in order to protect that capacity and to enable us to enable NHS boards to deploy staff who would maybe normally be involved in elective care to be able to staff both ICU and to provide extra capacity in emergency and unscheduled care as well. There was also the Louisa Jordan development as well.
We'll talk about Louisa Jordan in a moment. Capacity is effectively multifactorial, isn't it? It's having physical beds, it's having ventilators, it's having the staff, the sufficiently trained staff to man the ventilators, to treat patients. It's having enough people to repair the ventilators and to clean them and to do all of the sort of backroom efforts as well. But presumably some of those factors are an awful lot easier to predict and manage than others because, as you say, doctors and nurses and staff get sick themselves. So when you talk about expanding ICU capacity and indeed just general NHS capacity, how do you bring in extra sort of human capacity as the pandemic progresses?
So what we did in relation to that was we issued a call to people who were recently retired, people who maybe had been working in the healthcare professions and weren't any longer. The regulators, the GMC, the Nursing and Midwifery Council, supported all UK governments in terms of being able to get people back onto the register. We had one of our health boards supported us to set up a portal which enabled people to register their interest and desire to come back and support NHS Scotland, not just NHS Scotland, but also social care as well. And through those portals, NHS boards were able to identify, and social care organisations were able to identify people who were able and willing to come back into the system of support. So we did attract new staff in the early stages of the pandemic. We also brought students, so final year students, medical students and nursing and AHP students came into the wards to work as well.
So you stepped up that capacity in the early stages by closing down wards, as you've already said, and closing down electives. That occurs sort of fairly early on in matters and when everyone is in sort of crisis mode, I suppose is the way of putting it. But that the capacity issues continue for some time, don't they? Because if we have up, please, INQ 000274150, which is a slide that we looked at last week with the statisticians. So I'm not going to take you through the statistics in that way. It's page 15, please. What we see here is the number of per capita rates of COVID-19 patients in hospital. So we see the peaks of the early pandemic when capacity is being increased. We'll ignore the change in methodology for this purpose. We don't need to get into that. October 2020, there's the second wave, as it were. And then what I want to look at is effectively the third wave, the October 2021 peaks that we see there. Because I'll come on in a moment to what that looked like on the ground, but we see, don't we, that in Scotland, in that period from sort of September 2021 onwards, there is a large part of the time when there are more patients per capita in a hospital in Scotland than there are in the UK with COVID. So there is all of a sudden higher rates of COVID in hospitals in Scotland, not all of a sudden, but for quite a sustained period at the back end, second half or back end of 2021. If we therefore can have up, please, and before we do, I appreciate, of course, that this is only to deal with COVID patients. There's a whole load of other patients that require treatment at the same time for different things. So this doesn't tell us how full the hospitals are. It tells us that there are more people in hospital with COVID than elsewhere in the country. So if I take you, please, to INQ 000360218. It's a series of, I'll take them very briefly. Okay. We've got problems in capacity in terms of ambulances not being able to, so ambulance services stretched to breaking point, we see that in that article, and they have problems with not being able to, so the ambulance service themselves are struggling, but equally one of the problems that is attributed to that is they can't offload their patients in hospital because A&E wards are, A&E is stretched past capacity. Is that fair?
Yes, absolutely. The system was under, that's about the time the Omicron wave hit Scotland, and you see from the earlier graph that Scotland had a much more severe increase in that period than England. I think England sort of then caught up with us around Christmas time, but essentially we went into winter earlier than we've gone into winter previously in terms of pressures.
And it meant various very drastic steps had to be taken in hospitals. So non-urgent operations were cancelled, I think, in a number of trusts. Public was asked only to ring 999 in circumstances of immediate life-threatening emergency. And subsequently, the military were drafted in to assist with things like ambulance driving. That's right.
So if I just say, we had already, through COVID, we had introduced a reform of urgent and unscheduled care. So we were already trying to ensure that people who maybe didn't need urgent care were effectively triaged through our NHS 24, our 111 service, and therefore kept away from the front door of our hospitals. We also had a significant extra investment going into the Scottish Ambulance Service, which, as I say, unfortunately, the Omicron hit us a bit before we would normally expect to get into winter pressures. But yes, it was an extremely difficult period. It wasn't consistent across the whole of Scotland. So I think Omicron tend to focus across the central belt of Scotland. But our systems had been trying to get back a bit more into business as usual. So hospitals were very full, hence the difficulty with offloading ambulances. Yeah.
And the Royal College of Emergency Medicine, I think in September, said we need more beds. We need 1,000 more beds in order to try and get us over this issue. Were those beds forthcoming?
The approach that we've taken to increasing capacity in NHS Scotland is to focus that capacity on where people need it. So with I suppose the mantra behind that being about we only want people to be in hospital if they absolutely need to be in hospital. So we have focused a lot on what we can do to support people not to turn up to the front door in the first place, either through being triaged in 111 or the ambulance service, who do an amazing job of actually seeing and treating people rather than conveying them to hospital. We've also worked on hospital at home. So in response to your question, hospital at home provides that level of service to people in their own homes rather than in hospital. And I can't recall exactly what capacity we're at on there, but it's something like the equivalent of 3 district general hospitals. So we have increased capacity, but we've not always done it in the acute hospital sector.
And the acute hospital settings were being overwhelmed for not blanket across Scotland.
That's correct.
But there were a number of trusts who were on critical footings in October 2021.
Yes, there were periods.
And were not able to provide the service as a result of multifactorial issues. But COVID being part of that, 18 months into pandemic. That's right, isn't it?
So absolutely, COVID is part of that. There is a new infectious pathogen in our system that we didn't have before. We were also coping with the impact of the first waves of COVID, and particularly seeing that people who were presenting, particularly A&E, were sicker than they had been previously. So what impacts on hospital occupancy is also the length of time that people spend in hospital, and we have seen that occupancy rise, so people spending slightly longer in hospital, which is partly a factor of that demographic of people being older, frailer, more multimorbidity, but no doubt COVID's had an impact as well.
Were lessons simply not learned in the first 2 waves, such that by the 3rd wave, when you had those warnings, the capacity simply hadn't been increased sufficiently? So
I think lessons absolutely were learned. Omicron, I think, did the severity of the Omicron wave and the time at which it hit earlier than we were expecting it.
Melody, is that a convenient moment?
Yes, of course. 25 to 12, please.
Thank you very much, Melody. Thank you, my lady.
Ms Alledged.
Just before the break, we were talking about capacity. I just want to touch very briefly on the Louisa Jordan, if I may. The 20th of April 2020, Louisa Jordan was opened in Glasgow, SEC. This was, I think, it had 300 beds as an initial capacity, with the option of scaling it up. In terms of I appreciate you weren't in that particular post at the time, but in terms of actual use of Louisa Jordan, what was the hospital in fact used for?
So fortunately, we never had to use it in relation to sort of, overflow, because other facilities were unable to cope. What we did use it for, NHS Greater Glasgow and Clyde used it for outpatient clinics once we started to get back a bit more towards business as usual. And then it was used intensively as a vaccination centre as well.
And how was it staffed, in light of what you said earlier about the ability to bring in staff?
Yeah, so when NHS Greater Glasgow and Clyde were using it for outpatients, that was NHS Greater Glasgow and Clyde staff who were deployed, and obviously it was a site that was away from areas where people with COVID were being treated.
When it was being set up, how was it intended that
how was it intended? My apologies.
No, I was going to come into
yeah, my apologies. That it was intended that we would use some of the staff that we were getting through the portal, but that also that we would use staff from within our other boards, and again that might have been redeploying them away from what might have been their original duties, given that we weren't undertaking planned care at that point.
Why was the decision taken to decommission Louisa Jordan in April 2021?
I think the main reason, so at that point it was being used as a vaccination centre, but it was part of releasing the SECC to get back to business as usual, particularly in advance of hosting COP26.
Was the issues of capacity we were talking about just before the break, was any thought ever given to sort of recommissioning it or doing something similar in order to assist with the overwhelming of the NHS in the later half of 2021?
I think, I'll just relate to my earlier question, I think in terms of the issues that we have around managing hospital capacity, the focus there needs to be on making sure that we've only got the people in hospital who need to be in hospital, so ensuring that once people are ready to be discharged, they are discharged. We do still have challenges around delayed discharges, and building more out-of-hospital capacity as well, particularly through hospital at home.
Another topic, very, very briefly. Nosocomial infections. Yeah. The Enquiry, of course, will be looking at healthcare in more detail in future modules. So this is very much a sort of narrow issue in terms of Scottish Government decision-making in this regard. There was a review group established in May 2020, wasn't there, to look into nosocomial infections. Why was it formed then?
I think it was formed then. So we already have in place processes, advisory groups around nosocomial infection. I think that particular group was put in place to bring some additional capacity into that work.
Because as the pandemic progressed, people were still getting COVID in hospital settings, despite the fact that infection control and the like were probably better there than anywhere else, or should be better there than anywhere else in the community. That's right, isn't it?
Yes, that's correct, and I think that there's a role for everybody working in health and social care to stay vigilant around infection prevention control. We launched a campaign around, I think it was called "It's Kind to Remind," which was about just remembering that infection prevention control is just as important in the non-patient facing areas in hospitals as the patient facing areas. So we've spent a lot of time trying to ensure that people understand and are able to comply with infection prevention control, but it is something that not just for COVID but for other infections people absolutely need to stay alert to.
The inquiry has evidence, and there has been evidence heard elsewhere about, and again, this is something that will obviously be covered in more detail in future modules. It arises in this regard out of evidence given last week by Dr. Jim Elder-Woodward and the concerns in the disabled community, of DPOs in particular, in relation to access to treatment and DNA CPR, so do not attempt cardiopulmonary resuscitation. The inquiry has heard evidence and seen evidence that one of the health boards in Scotland published a COVID triage document online for a period, which set out sort of how patients would be triaged in terms of accessing healthcare. Can you comment on that?
I'm sorry, I can't. I haven't seen that document.
Okay. I want to take you back, well, not back, but you say in your statement, paragraph, or page 11, so IMQ 000315534, page 11. Paragraph 35, talking about sort of ramping up infrastructure and ensuring that there's infrastructure in place in the course of a future pandemic, or in terms of testing, vaccine, necessary infrastructure at the time had to be largely built from scratch. And I think what you're saying here is make sure it doesn't have to be built from scratch again, keep the structures in place to some extent.
Yeah, absolutely.
You then say at paragraph 37 of your statement that better management of any future pandemic, regardless of the particular characteristics of that pandemic, will rely on the ability to ramp up key public health infrastructure. You then say much of this has already been stood down as a result of the withdrawal of UK funding, UK government funding. But it's right, isn't it, that the way funding works, Scotland gets a block grant for health, and Scottish ministers decide as part of their role how that funding is allocated, don't they?
That's correct. I think but I think we also have to pay attention to the fact that during the COVID pandemic there was additional funding made available specifically for areas such as testing and the lighthouse labs, etc.
There's additional.
Sorry for interrupting. I thought the block grant was block grant generally, and then the Scottish Government decided. I think your question said a block grant for health.
Sorry. Funding is allocated in a block, and it is allocated by Scottish Government to whatever areas they choose to allocate it to. So whilst you say that this has been stood down as a result of UK funding withdrawal, some of this infrastructure, what steps have been taken within your directorate and more broadly to maintain the level of capacity that you think is appropriate?
So I'm sure you will have seen evidence that Scotland's established a standing committee on pandemic preparedness, and that has issued its draft report. It's due to issue its final report this year. That is looking at the establishment of a Scottish Centre for Pandemic Preparedness or Planning. I can't remember exactly what it's due to be called. I think in terms of what we have done so far is we have tried to, as economically as possible, maintain the sort of core capacity to be able to ramp up a bit. A lot of that is around some of our digital capacity, some of our data flows. But the fact remains that were we to need to go back to sort of mass population level testing again, then that is something that would need to be funded on a four nations basis.
But it doesn't preclude the infrastructure remaining in place, so that it is not a question of going back to zero.
I think you can keep some of the infrastructure in place, but it would still require significant additional investment to ramp that up and get it going.
Phase. My Lady, have you got any questions?
No, I have no questions. Thank you very much. Forgive me. I always try to cough when I'm out of the hearing room. Thank you very much indeed, Ms. Lamb, for your help for the second time. I'll try not to call on you too often, but I can't guarantee there won't be another
expect we'll be
occasion.
meeting again.
Thank you very much indeed.
I'm grateful, My Lady. We now play a bit of musical chairs in the benches.
Lady, the next witness is Professor Sir Gregor Smith.
Stand. Repeat after me. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Please.
You are Professor Sir Gregor Smith.
I am.
I was planning on addressing you as Professor Smith. Would that be appropriate?
Absolutely fine.
Thank you. You have helpfully provided a statement to the inquiry, Professor Smith, which is under reference INQ 000273978. Is that your statement there?
It is.
You're familiar with the statement and have had the opportunity to go through it in advance of giving evidence?
I have, yes.
Does the content of this statement remain true and accurate as far as you're concerned?
As far as I'm aware, yes.
Thank you. You are currently the Chief Medical Officer for Scotland, is that correct?
That's correct.
And you originally trained as a general practitioner.
I did, yes.
You were formerly a medical director for primary care, I believe, in NHS Lanarkshire.
That's correct.
And you began working for Scottish Government as a medical advisor in primary care in 2012.
That would be correct, yes.
I think there was an element of your work at that time that was the particular focus of your initial engagement relating to the Scottish GP contract, is that correct?
So during that initial period within Scottish Government up to 2015, I was a senior medical advisor in primary care, and part of the remit there was involved in the development of a new GP contract in Scotland.
Thank you. And you were appointed Deputy Chief Medical Officer of Scotland in 2015.
That's correct.
You were appointed Interim Chief Medical Officer on the 5th of April 2020.
That's correct.
You were appointed to that role at the point when the previous Chief Medical Officer, Dr. Catherine Calderwood, resigned.
Yes.
And you subsequently became the Chief Medical Officer for Scotland on the 23rd of December 2020.
That's correct.
Could you please give us a broad outline of the roles of both the Chief Medical Officer and the Deputy Chief Medical Officer, the latter being the role that you held at the beginning of the pandemic?
So in relation to specifically to the pandemic, the Chief Medical Officer was the principal independent clinical advisor to Scottish ministers and to officials. The role of the Chief Medical Officer in relation to the pandemic was to try to collate as much evidence as was possible about an emerging threat which had been identified relating to a novel coronavirus disease emerging in China at that point in time. The DCMO, the Deputy Chief Medical Officer's role, was to support the Chief Medical Officer in doing that, but also at that time, a large part of my role was to take care of a lot of the other business that related to the office, and to try to keep that business as usual property going.
Thank you. There is another prominent role within the advisory structure of the Scottish Government called the National Clinical Director. Is
That's
that correct?
correct.
And that post was held during the course of the pandemic by Professor Jason Leach.
That's correct.
I believe that role to be a unique role when comparing the advisory structures in the United Kingdom. Could you please explain broadly how it is that the duties of the holder of that role fit in with the duties you just explained, in particular focusing on the beginning of the pandemic?
Professor Leach will be able to give you a much broader assessment of how his role worked at that point in time. From my perspective, the National Clinical Director's role has always been complementary to that of the Chief Medical Officer, but focused on a slightly different remit. National Clinical Director's remit has been broadly facing the NHS within Scotland rather than public health up until that point. And at that early part of the pandemic response, I am unaware as to the full extent of the National Clinical Director's involvement in discussions with the CMO at that point in time.
Right, I understand.
My understanding is that the National Clinical Director was very focused on preparation of the NHS.
Right. And given that you subsequently became the interim Chief Medical Officer and then Chief Medical Officer towards the end of 2020, can you broadly explain for Her Ladyship how it was that those roles developed as the pandemic went on and the requirements from medical advisors perhaps changed?
It was very clear to me that the scale of the threat and the response that was required to that threat required much more capacity clinically within Scottish Government advisory circles than we had at that point in time. So I recruited additional staff when I took over in April 2020, but also sought to involve the skills that the National Clinical Director and indeed the Chief Nursing Officer, the third part of the senior clinician triumvirate which existed within those advisory structures, to try to make sure that they were very much more involved than perhaps they previously had been in sharing the advisory duties. That involved not only linking back to how we became involved with ministers and providing that advice, but also how we engage with the public as well in relation to that advice.
Thank you. Would it be correct to say that the ultimate role of the Chief Medical Officer is to provide medical advice to the Scottish ministers to help them inform their decisions?
Ultimately, I think that's correct, yes.
And although, as you've already helpfully explained, the Chief Medical Officer will draw on a lot of advisory systems, and no doubt also on the Deputy Chief Medical Officer and National Clinical Director and others, the ultimate responsibility for that provision of medical advice to ministers sits with the CMO.
Ultimately, the CMO's responsibility is to offer that advice to ministers from which they can then base decisions.
Thank you. We'll hear some evidence later today from Professor Sheila Rowan, who is, as I understand, a Professor of Physics and Astronomy at the University of Glasgow. She performed the role of Chief Scientific Officer to the Scottish Government, at least for the early part of the pandemic, before another person took that role over. We also know that there's another post called Chief Scientist Health, and I understand that that role was held predominantly during the pandemic by Professor David Crossman. Have I got at least all the personalities correct?
The personalities you've described there are absolutely correct.
Thank you. And as far as scientific advice is concerned, is it correct to say that the Chief Medical Officer ultimately also provides advice to the Scottish Government on scientific matters, in particular insofar as they related to the pandemic, including in relation to the role of things like vaccines, the efficacy and availability of testing, the efficacy and availability of PPE and the like?
Yes, the Chief Medical Officer helps to coordinate that advice from a variety of specialist advisors. You've mentioned some of them there. The Chief Scientific Advisor for Government is one, an important one, which again, going back to an earlier point that you made in terms of how we utilise all the assets within the team that we have, was the Chief Scientific Officer for Health. Professor Crossman was a very able individual who I thought was could contribute much more than he had been able to contribute up until that point. And we used them specifically in relation to some of those questions that you've posed there in terms of the the research and scientific basis for particular approaches such as testing.
So just to try and make sure we have the structures correctly, the CMO works within the CMO department or directorate, is that correct?
So the way that this works is the CMO Directorate is a unique director within Scottish Government. It's unique in some ways because it sits slightly to the side of other directors. What I mean by that is it has an independence which perhaps other parts of government don't quite have. I think a really important aspect of the role is that independent clinical and scientific advice that comes through the office. But within that directorate, there are a number of clinical advisors that I am the line manager to and responsible for. One of whom is the Chief Scientific Officer for Health, we've already mentioned. Another of whom, another really important figure in all of this, the Chief Pharmaceutical Officer as well, who's able to provide additional information and advice in relation to therapeutics.
The chief scientist, as I understand it, effectively sits structurally in a different part of the Scottish Government, not under the ambit of the Directorate of Health and Social Care, but of another directorate. I think it's the Economy Directorate, is that correct?
I think that is correct, yes, Economy.
For present purposes, it's in a different part of the Scottish Government. And is it correct to say that the post that Professor Crossman held was, to a degree, a bridge between the scientific side and the health side, in that he was Chief Scientist Health and therefore would have informed advice from both the Chief Scientific Officer and the Chief Medical Officer?
I would say that's a very good way of describing the role of the Chief Scientific Officer in Health, a bridge between many different parts of government, particularly in that research field. And an important aspect of research, of course, is to link back to other aspects of government, such as economy and learning as well, and to be able to bridge some of the kind of joint ambitions that the government would have in those areas.
You've described the importance of the independence of the Chief Medical Officer's department, but from an administrative perspective, it struck us that these arrangements are perhaps slightly complex. Was it to any extent a matter which caused difficulty in accessing the right people, making the most and best informed decisions, that these structures existed somewhat in different parts of the Scottish Government, or did you not find that in your role?
I can very honestly say to you that I did not find that in my role, and that actually access to other parts of government, access to getting the right staff was never an issue.
Thank you. You sat on a number of advisory groups and attended a large number of meetings during the course of the pandemic in your 3 roles, including SAGE, the Four Nations Chief Medical and Scientific Officers Group. Could you just say yes if that's correct?
Yes.
Sorry, thank you. The Scientific Influenza Group on Modelling, SPIM.
Yes. No.
No. The Scientific Pandemic Insights Group on Behaviours, SPIB.
No.
The Joint Committee on Vaccination and Immunisation, JCVI.
No.
The Joint Biosecurity Centre, JBC.
The JBC Technical Board.
The group that we've heard of before under the acronym NERVTAG.
No.
The UK Health Security Agency.
The UK Health Security Agency Board.
And you did sit on the Scottish COVID Advisory Group when it was formed.
Yes.
What was your role when attending these groups?
So particularly, if we start off with SAGE, I think SAGE is a good example. In the early part of the pandemic, as the Scottish Government began to receive invites to attend SAGE meetings, I attended SAGE as an observer to proceedings. My role there was to take account of the information and the discussion that was being relayed over the course of those meetings, and where it was necessary to try to kind of ask questions on behalf of the Scottish Government, to signal those. Generally, they had to be signalled in advance of the meeting. Latterly, whilst DCMO, there were other mechanisms put in place to try to signal questions to the committee during its operation. But that observer status during that period was essentially as an information gathering mission.
What, to stay on the UK level, what about nerve tag?
Yeah, I didn't sit in NERVTAG at all. NERVTAG is a very technical committee. It's generally staffed by people with expertise, deep expertise in infectious diseases and epidemiology. We had a representative on NERVTAG from other sources within Scotland who were able to feed back when it was relevant and appropriate for them to do
Indeed. We heard from Dr. Jim McMenamin on Friday, for example, who sat on that group.
And Dr. McMenamin is one of the unsung heroes in terms of the approach that was taken in Scotland, a man who I have enormous respect for.
Thank you. You also sat on the Four Nations Chief Medical and Scientific Officers group. Could you explain your role in that group?
The Chief Medical Officers group, so I suspect that the group that you're alluding to is the GBC Technical Board, which was staffed full of CMOs and the Chief Scientific Officers. And this was a board which was examining some of the technical parameters under which GBC would develop data or information for use. A good example of that might be the data that was developed and the approach that was taken in terms of assessing risk of other countries at the borders with the UK and people returning or travelling to those countries. So we gave advice on some of the parameters which data would be useful technically to assess that.
Thank you. We'll hear more, I think, later in the week about the precise circumstances in which the Scottish COVID Advisory Group came together from other witnesses. But as far as your role on that group was concerned, what was your role? In particular, was this a group that reported effectively or offered its advice to ultimately to Scottish ministers through you?
The group operated in a way whereby advice that came from that group was provided to me and to the Scottish ministers, and it was set up in a way to try to allow a greater interrogation of the data and the evidence that they were considering. Whilst I was a member of the group, its extreme usefulness was in the ability to be able to actually get into discussion with members of the group in a deep way at times. Sometimes that would be through the chair, sometimes that would be by attending the meetings himself and being able to kind of, in a two-way mechanism, be able to both relay information that I was party to, but also hear the discussion and interrogate the discussion which was going on within that group as well. The advice that advisory group was able to provide to us was incredibly useful. Much of it was based on the same evidence which was being considered in other places, but the ability to be able to kind of have that discussion in first hand with those people was incredibly valuable.
Thank you.
Professor, if you could slow down a bit. I'm afraid you're falling into the same trap the rest of us fall into.
Thank you. Professor, there's a stenographer, obviously, who is attempting to keep up with your very useful evidence, so if we could just try and take it as slowly as we possibly can. I'm often admonished for the same thing, I have to say. You've given some helpful evidence about the structures through which medical advice was able to be provided to the Scottish Government during the course of the pandemic and more generally. The inquiry has already heard evidence about the structures which existed at UK government level and the key individuals involved, not least Professor Whitty and Sir Patrick Vallance. These were individuals who, we've heard evidence, came from, in Professor Whitty's case, a public health background. Is that correct?
I think Professor Whitty's background is in both in public health and infectious diseases. Indeed.
And I think the inquiry has also heard evidence in the previous module that Sir Patrick Vallance came from, he's, as I understand it, a clinical pharmacologist who had experience of working within industry relating to the development of pharmaceuticals and the like. Also an element that was very relevant to the pandemic response. Is that correct?
Yes.
In Scotland, the three main individuals whom we've looked at who provided medical advice to the government came from different medical backgrounds. Is that correct?
Yes, we all came from different specialties.
You've already helpfully told us that you came from a general practice background and worked through various government jobs. Dr. Calderwood, I think, came from an obstetrics and gynecology background, is that correct?
That's correct.
And Professor Jason Leach was originally trained in dentistry.
That's correct.
Before taking qualifications in public health at various university institutions after that.
That's correct. As far as
would it be fair to say that given the particular requirements and difficulties faced in the pandemic itself, that the background and experience which you and your two colleagues were able to bring to bear to providing medical advice meant that you required more, perhaps, than the UK government advisors to translate the advice of others more expert than you in the matter?
I don't think that's correct, no. I'd been working in population health and public health and since probably 2006 in various leadership roles between managed clinical networks to medical director roles to subsequently 10 years of experience within Scottish Government working at a population health level as well. So I don't think it's correct to say that. But what I will say is that the information and the knowledge which was used over the course of that response necessarily came from a wide group of very specialist people, both within the health protection community and the infectious disease community, and their input was incredibly valuable.
But ultimately, as you have, I think, accepted and explained, the ultimate role, as far as providing advice to the Scottish ministers are concerned, falls to the Chief Medical Officer. And neither you nor Dr. Calderwood were, like Professor Whitty, experts in public health and infectious diseases in that way.
My core specialty wasn't public health, but I would still regard myself as having expertise in population health and public health.
I should say, Professor, I mean no disrespect at all in that regard, but the reason I asked the question is because during the course of the pandemic, it was often part of commentary of people who are wondering whether they had to continue to adhere to restrictions, that the medical advisors who would appear perhaps didn't have the same level of expertise as the UK government medical advisors. Was consideration given in the public communications strategy, at least, to the need to try to win the confidence of the public in order to try to maintain compliance, and these particular comments rather than criticisms that were sometimes made?
So those comments that you have singled out there, I don't particularly recognise as being something which was an issue which was raised at all. What was important was that credible and authentic clinical leaders were able to discuss with the public the requirement to undertake the very significant ask that we made of them, and to try to explain in very simple terms as to why that was the case. I think it's something that we did in Scotland very well, certainly judging by the feedback that we had through some of the polling. Public confidence in that messaging was very, very high, and we saw really quite significant compliance from the public in relation to taking the, as I say, those just quite incredible steps that we asked of them to try and to keep people safe. So I don't accept that the background specialty that I have as a GP had any influence in that whatsoever at all. Thank you.
You've referred to some polling as regards the communication strategy about which the inquiry has already heard some evidence. Professor Paul Kearney, Professor of Political Science, looked at this issue in an expert capacity and suggested to the inquiry last week during his evidence that it was important to maintain a distinction between when people indicate a satisfaction with the way in which information is being presented, as opposed to the possibility that may not necessarily indicate an understanding and hence compliance with it. Is that a distinction that you recognise?
I would be really interested in reading more about what he says there, and I think that we observed both a high degree of compliance and satisfaction with what was asked of the public.
Thank you. The phrase "following the science" is one which one hears often in connection with the pandemic and was used by a number of politicians to describe their response. Do you think that this is an accurate description of how policy decisions and ultimately strategy in fighting the virus were made within Scottish Government?
I'm not quite sure where that phrase originated from, but it's one that certainly became quite commonly used over the course of the pandemic response, certainly in the media. What I observed was a thirst for information and knowledge from those who were making the decisions, and they looked to science to try to provide that information and knowledge so that they could try to make sense of the decisions that they were being asked to take. And what I found was a very receptive group of decision makers who understood the limitations of some of the evidence and the science that was being presented to them, but also made great efforts to try to actually get under the bonnet and understand the science itself, so that they weren't wholly reliant on just people explaining it to them.
What was it that gave you the impression that decision makers ultimately understood the science itself?
The questions they asked me.
Could you give some examples, perhaps?
The questions,
it's a broad question.
So the questions which began to be asked in relation to aspects of the response, whether that be modelling, whether that be transmission dynamics, whether that be even rudimentary epidemiology, such as understanding of the R rate, over the course of that, even the early part of the response, the questions which came from those decision makers began to become very insightful into not just the information that was given to them, but for the logical next steps that flowed from that as well.
Thank you. Given the complexity of the information, some of which we've seen presented in documents such as, for example, the SCORE SITREPs, with which you'll be familiar, do you think that there were stages of the pandemic in which politicians did follow the science in Scotland?
Yes.
Well, we'll get on to the precision, but I just want to finish the question. Were there times when you felt that they did follow the science? And can you specify for us what time periods you think that might apply to?
One of the things which was very evident over the course of the discussion with senior officials and with ministers was an appreciation of what science could offer in terms of informing how to respond to the threat of the coronavirus. Some of that was about understanding the epidemiology and how it was likely to transmit through populations, and therefore shaped the type of response that was going to be required to reduce transmission. Some of that was about the clinical response that was going to be needed in order to treat people who'd become infected with coronavirus. There was a process by which we used that science and started to begin to integrate other fields of science into strictly speaking would be health and public health research, and begin to integrate research from other areas such as behavioural science, how people might respond to a particular ask, how people might be feeling in terms of the degree of threat that they were facing. And the Four Harms process, which subsequently became part of the way that we handled the pandemic in Scotland, tried to take evidence from government advisors across 4 different aspects of harms that we'd identified, and use science and research from those areas, evidence from those areas, to try to integrate a response that was balanced in terms of its approach, and recognised the various harms that both the coronavirus itself would cause to the population, but also the potential for the response to cause as well.
Thank you. You said, I think, that certain scientific disciplines were introduced into the analysis as time went on. Yeah. You referred in particular to behavioural science. When was it that was it at the advent of the Four Harms strategy that these different scientific disciplines were brought to bear?
I would recall it as far back as the March 2020 that some of these responses were beginning to become much more clearly integrated into the response, understanding, particularly in terms of the degree of the ask of the population, how they might respond to that. And even at the very early stages of forming the C19 advisory group, we made sure that we had representation from behavioural scientists on that group, which was further strengthened later on in 2020, I think.
Does it mean that decisions before around the formation of the COVID-19 advisory group were not informed by this wide range of scientific disciplines?
I think that at the earlier stages of the response, there was less emphasis given on the behavioural aspects of the response than perhaps there were by the time that we had reached some of the major decisions in March 2020. However, there was perhaps a greater reliance in those early stages of the type of advice which was coming from groups such as SPI-B, which have been set up as part of the SAGE infrastructure to look specifically at the behavioural response.
Would it be fair to say that the logic of the position in introducing behavioural science around about the time of the formation of the Scottish COVID-19 advisory group was that it was important that there was a local consideration of the way in which Scottish people would react to restrictions, which had not previously featured in the analysis?
I think that that was a helpful part of their involvement. I think that there was also insights which were developed from other places as well. And my observation would be that many of the political decision makers who were present at that time were very good. In fact, some were exceptional at judging both the mood and response of the population.
And how did they go about doing that? Was it the polling that you've referred to or something else?
I think some of the information came from polling. Some of the information came from their own personal insights and discussions with both constituents and the many groups which they were in contact with.
Was it ever part of, or if it was, when was it part of the Scottish Government's approach to the fight against the virus that no death from coronavirus was acceptable?
It's not particularly a phrase that I recognise. Certainly from a clinical perspective, there was a deep realisation that, tragic though it is, and it was an absolute tragedy for some families, that it was almost inevitable, given the scale of the threat which was faced by a novel virus in a population that had no immunity to it. It was likely that there were going to be deaths. And what we sought to try to do was to try to limit the harm as far as we possibly could, to limit not only deaths as far as we could, but also the other harms which arose as a consequence of illness from COVID-19 as well. We should forget that COVID-19's a disease which not only causes the risk of death, but actually has long-term effects for many, many people as well.
Indeed. So to put my question in the context of the 4 harms strategy, which you've helpfully referred to, was it, and again, if it was, when was it, part of the Scottish Government strategy to prioritise harm 1, which was, we recall from previous evidence, COVID-related harm, as opposed to the other harms?
As far back as I can remember, it was the priority to try to reduce the direct harms which were being caused by COVID. That had been identified as certainly the most significant and pressing, urgent threat to the nation. And there was a recognition that actually left unchecked, the harms that the virus could cause would be far greater in the scale than the harms which would arise from some of the other 4 harms which have been identified. And by prioritising the direct harms, by reducing the displacement effect on the health services, and by trying to control and indeed suppress the growth of the virus, then that would actually allow the best chance to be able to reduce the harms in the other 3 areas as well.
Okay. Was it the case, we know that the 4 harms group eventually formed in October 2020, though the Four Harms strategy, the framework, had been laid out in April. Over that period before October, was it the case that the priority remained harm 1 over the other harms?
During that period that you're describing there, from probably from April through to October, it certainly appeared to be the case that harm 1 and harm 2 were given a significant degree of priority during that period. It was recognised that in the initial response there was a great deal of displacement in terms of other health need within the population, and during that period we started to try to recover aspects of the NHS at the same time to be able to try to address some of that unmet need that there was in the population as well. But it certainly was my view that during that period those two harms were given priority over the other two areas, though it has to be said that some of the responses during that time were still tempered by the recognition of potential harms in those other areas as well.
And given the priority which you say was given to harms 1 and 2 over that period, when you were providing medical advice, if one might describe that as the policy of the government at that stage, when you were providing medical advice, did you tailor your advice to that policy?
The advice that I gave at that time was advice that was designed to reduce the harms in harm 1 and harm 2 as much as possible. It was for other advisors to give advice in relation to harms 3 and harm 4. It was the integration of the advice from a range of advisors which then allowed the policy to be developed and for decisions to be made by ministers. But my priority, and I saw very clearly my priority, was to give advice solely on the benefit to reducing harm 1 and harm 2.
Those being harms related to health, broadly speaking.
Yes.
You mentioned there the integration. To what extent were you afforded the opportunity to discuss and compare and contrast and integrate your views on harms 1 and 2 with the other advisors you've described as being more responsible for harms 3 and 4?
So very early on in the pandemic response, myself and the Chief Scientific Advisor had discussion about what we recognised was perhaps a benefit in forming a whole new group for the chief advisors from different parts of government. Prior to the pandemic response, it certainly didn't seem that these chief advisors met on any kind of regular basis. But I saw, and I think the Chief Scientific Advisor very clearly saw a benefit as well in trying to bring people together in a forum that allowed us to consider a variety of types of evidence to look to see the broader impacts on society. That was a good forum for being able to discuss some of these impacts and really to gain a better and broader understanding of the impacts that we were beginning to see across different aspects of society. It's always been recognised right from the beginning of the SAGE discussions that any response to try to control this pandemic was likely to have broader harms than simply the direct harms that we saw from the virus itself. So recognising then and understanding what those type of harms were likely to be, and then trying to risk manage those to mitigate and reduce the level of harm which we were seeing in those other areas was an important part of that response. And we should remember that ultimately any harm which befalls as a consequence of either social or economic detriment to the population also has a detrimental public health effect as well. If not in the short term, then it can perhaps be felt in the medium to longer term. So there was a benefit in being able to try to reduce those harms as much as possible, mitigate impacts on a public health basis as well.
So that was the theory. Is that right?
That's the theory.
The inquiry's heard a considerable body of evidence, which might be summarised in an expression used by someone who appeared in the opening video that we played. He said that when Scotland tried to emerge from the pandemic, emerge from the lockdown in the period I think that we were talking about, he said nobody took a look around to work out whom we had left behind. The way one might interpret that is that there continued to be a significant focus on harm one for too lengthy a period, and that the other harms, the harms caused by the countermeasures, broadly speaking, were not given sufficient attention over that period. Would that be a criticism which you would recognise as regards the practical impact rather than just as regards the theory?
It is a criticism. It is a story that I've heard from accounts of beforehand. Being part of those discussions when the variety of harms that we were seeing occur across the country was being considered. The way that advice was then taken by decision makers, I think, reflected where their perception of the greatest risk to the country existed. And ultimately, any prioritisation of any harm over another probably reflected the risk thresholds of those decision makers.
The four harms group did not meet till October 2020, is that correct?
It did not meet on a formal basis in that time, but there were many discussions before that.
By October 2020, Scotland had started to become overwhelmed by harm one again, hadn't it?
What we saw in starting generally from the early autumn period was, first of all, significant outbreaks and clusters developing across the country. Largely inevitable, as we still had a largely naive population in terms of immunity, and we saw more and more clusters developing over that early autumn period, so that by the time we got to that kind of late autumn, early winter period, cases were certainly significant again, and there was a significant concern from a health protection perspective that if that wasn't controlled, if that wasn't reduced, and if we didn't manage to achieve lower case numbers and control over the prevailing R number in Scotland, and then entering that winter period, it was only likely to increase.
We saw in some statistical evidence that the cases in Scotland started to rise significantly, I think, from around August.
Yeah.
And I think there is subsequent evidence from scientific study that suggests that that was in large part connected to people bringing the virus back from being away in continental Europe, in particular Spain.
I agree.
Yeah. What I'm suggesting to you as regards the strategy is that although the theory had been laid out in the framework in April, the fact that a committee had not met till October, a time at which Scotland had started by circumstance to become overwhelmed again by harm one, the virus having returned, did this mean, was this the reason why people, like the gentleman said, were left behind and the other harms were not properly integrated into the response?
What I saw in that period that you're describing between April and October was regular discussion in relation to the four harms and how they were integrated together. So the fact that a committee did not meet during that time shouldn't be understood that there wasn't a great deal of discussion about how you balance those harms in that period.
A great deal of discussion, perhaps, Professor, but perhaps little effect.
I would think that you would probably observe that from the submissions which were made to kind of cabinet, for instance, during that period, that there was consideration of those four harms in that period as well.
Could I turn to another subject, please? What was your understanding of your responsibilities with regard to the use of informal communications in the 3 posts that you held during the course of the pandemic as an employee, as I understand it, of the Scottish Government?
So informal communications, as I've outlined in my statement, have been used were in a way largely for to raise situational awareness, to kind of direct people towards particular pieces of information, to convey information about particular meetings which were taking place, which were used to try to arrange, in some cases, discussions or agreement around about particular situations. you will see from some of the groups which have been submitted and that I was a part of, I have described that whilst these meetings, or that way of communication was useful for that purpose, that any information which was particularly pertinent or any decisions should be captured and put into email form.
I think it's correct to say that evidence has been given during the previous week that it's not just a question of decisions being captured in that way, I think in order to put them on what's called the corporate record, but that discussions engaged in which individuals engaged in the pandemic response also required to be recorded that way. Is that not correct?
Pertinent information, yes, and I think you'll see from one of the conversations within and the advice I give to participants in one of the chat that's how it should be captured.
Could we look at INQ 000334433, please? This comes from a WhatsApp group chat, I understand, called CMO Weekly Call. And I'm particularly interested in going to this particular passage, which is from July of 2021. This is a conversation between yourself and Graham Ellis, in which he comments, "Hope this isn't FOIable." You say to him, "Delete at the end of every day," and he laughs and puts his thumb up at that. Was it your practice to delete messages at the end of every day?
Scottish Government advice in relation to this was not to retain information for longer than it was necessary, was to make sure that any information which was pertinent, as I say, any information, particularly discussions, which ended up in a decision, was captured in within the corporate systems. So my practice was to make sure that any information which was important in that way was then captured in email form on the system, was formally recorded so that it was an auditable trail. And I think you will see the evidence of my approach to this within the conversations and within other conversations, that I exhort other members of those conversations to do the same. And but my practice was, when information was no longer useful, it shouldn't be retained.
My question was whether you deleted your messages at the end of every day.
If not at the end of every day, then certainly on a frequent basis, I deleted information which was no longer needed to be kept.
But your position is that, as far as you're concerned, you would have, before doing so on a daily basis, extracted pertinent information from the exchanges, sent them onto the corporate record by email, and that those emails would then have recorded the information that was within the message before you deleted it.
So any important decisions that were taken, it wouldn't be a verbatim account of a conversation, but it would be the essence of any decision or any approach which should be taken, or any information that had been given. Generally, what I found was that the information systems like this were used to convey information about exchanges which were either already beginning on emails, or information which was being passed on through emails, documents which were being passed on in that way.
You referred again in your answer there to decisions. So does pertinent information, as far as you're concerned, mean information which demonstrates that a decision has been taken?
The most important information which was about definitive information, which may include a decision. So once perhaps a consensus has been achieved, what that consensus was.
I took from what you were saying a moment ago that there was someone had informed you that there was a need or impetus towards not retaining too much information, and that was an important part of your thinking in this regard. And of course, organisations like the Scottish Government can't keep every piece of paper and every document or every WhatsApp message. Where did the impression of that being the impetus, which should be an important part of decision making in this regard, come from?
So there was advice given to Scottish Government employees which specifically dealt with informal messaging and the need to delete on a regular basis any information which was not relevant.
Can you remember in particular which advice? Because there were a number that you were relying upon.
I think this was advice which was the one I recall was perhaps on the Saltire website, which has been given out towards
There was one that was issued on the Saltire website in April 2020. Was that perhaps it?
It would be towards the beginning.
Yes, we looked at that with Ms Fraser on Friday, but that would be the one that would have
So
guided
that would
you.
be one, but there was also advice which was given and reminders which were given in discussions with the then Director General, who again reminded us that official business shouldn't be done within these mediums, and that there should be regular deletion, partly for security purposes, from that medium as well, and that it shouldn't be seen as a secure medium.
At that time, just to be clear for the personalities again, the Director General was that Mr Wright.
It wasn't at that stage. That I don't recall that instruction coming from Mr Wright. I might be mistaken, but I think it came from Miss Graham.
Thank you. Could I move on to a separate area, please? Obviously, as I've said at the beginning of today, the inquiry will not be hearing from your predecessor in the post as Chief Medical Officer. We are, of course, very interested in exploring matters pertaining to the early period of the pandemic, at which time, as you've helpfully explained, you were Deputy Chief Medical Officer. My understanding from your statement and from notebooks which you've helpfully provided is that you attended certain meetings at around that time, although as you have set out, you also had considerable responsibilities for parts of the NHS that were not directly related to COVID at that time. So would it be fair to say that there is a certain degree of limitation on what you can do to help us with the events of the period up till you becoming interim Chief Medical Officer, but that, of course, as you have done in your statement, you will help us as best you possibly can with your recollections of events?
I think that's fair to say. I think that during that period I did have involvement, and I participated in many meetings, even during that period, including incident management teams, including many of the SAGE meetings. I had quite a degree of involvement over that period. Where I had less involvement and where I may be able to help you less is in the direct discussions and the way that advice was conveyed to decision makers.
I think you say in your statement that Dr Calderwood undertook the majority of engagement with Scottish ministers and senior officials at around that period. Did you have conversations with Dr Calderwood as her deputy about the emerging information, the strategy, and ultimately what advice she would be providing to ministers?
We spoke on a regular basis in relation to the emerging advice, and we didn't speak just as much in terms of how she would relay that advice, or what advice was provided to ministers. There were a couple of occasions where I was able to kind of have direct discussion with ministers myself during that period, but that was probably by March that I would be involved in that way.
Would it be, we obviously, as I say, have had some access to some of your diary entries, including references to some of the SAGE meetings you attended. Would it be correct to characterise them, as you said earlier, as you being there very much in an observer role? It looks very much like you're trying to extract as much information as you possibly can. Your notes are quite full, and perhaps then take it back to feed into the decision-making system in Scotland. Would that be a correct characterisation?
I think that's a very correct characterisation. My role was as an observer at SAGE, was to try to glean as much information as possible. Perhaps there was a slight element of frustration that I couldn't participate in any deeper sense, and perhaps at that stage we were still to see the full usefulness of SAGE in terms of being able to actually become involved in the discussion at that point.
Well, that was precisely the issue I wanted to hone in on, was the frustration. You mentioned, I think, earlier that when attending SAGE, representatives or officials like yourselves and others who would be there had an opportunity to ask questions, but they had to be submitted in advance. Was that something you
That's
said?
correct.
And how long did that carry on for, that practice?
That practice probably carried on through the February and March period that I was involved there, but I think from that point onwards, probably late March, it became a much more integrated approach, and it became much more, much easier to be able to actually get involved in discussion and ask questions within the body of the meeting. There was one occasion in particular where most of the SAGE meetings were attended remotely, and at that time, this was before we really had any of the platforms which enabled video meetings. It was mostly done using kind of dialed-in telephones. The ability to be able to communicate in that environment was, I think, difficult. And on one occasion, at least, I remember travelling to London specifically to attend the meeting in person, just so that I could try to glean more information, but also have discussion with people who were there.
Just to be clear, the remoteness element you were talking about there, did that relate to the period before things got better towards the end of March, or was that the period after?
That would probably be, so the remoteness element would be during the initial stages of SAGE, particularly February and early March.
But as far as the input or the output, if you like, for Scotland generally at that stage, you mentioned feeling a degree of frustration at your inability to explore things. Could you expand on that a little further? What were the effects of your inability to engage in the way that you would have wanted?
So the impact of that inability to be able to explore during the course of the meeting meant that you then had to, rather than be able to deal with a particular line of inquiry or interest at the time, you had to chase down someone afterwards to try to find out more information. It expanded on the amount of work which was necessary to try to get a sense of an answer to your question. And
what were the sorts of Scottish-specific, I assume, issues that you were wishing to raise, and you're having this difficulty in doing so around that time?
So there were many and varied, and I wouldn't characterise them as being particularly Scottish-specific. I think that these were just general epidemiology questions which you wanted to ask, or particular clarifications about what data or modelling was suggesting. And these were not issues which were, as I say, generally specific to a kind of Scottish situation. These were about the wider virus itself.
Thank you.
Scotland on SAGE at the time you were?
Yes, there was representation there. Again, Jim McMenemy was one of the...
I was going to say, I thought there were others.
Yeah, and we used to compare notes afterwards, after a meeting, just to make sure that our understanding was broadly similar in terms of the approach. But as I say, having the observer status at that point in time did feed a little bit of frustration. That was corrected, though, and I should emphasise that was corrected.
Yes, it was corrected, I think you said, towards the end of March. Thank you. If that's an appropriate moment, lady, we can...
Certainly.
Thank you.
I shall return at 1:45.